Thank you. It's an honor to be here. So, to repeat some of what you've heard, we do have terrible problems with access. Many of those problems are for minorities, poor, and other vulnerable populations. Our cost is twice every other developed country, and the Commonwealth Commission said our score is 65 out of 100 for quality. And we have to address all of these concurrently, not sequentially. And my main point is going to be, somewhat like Professor Enthoven said, is that we must fix the delivery model. It is the bedrock of the other ones, and we must move from fragmented models of care to integrated systems of care. And I would like to put forth the concept that creation of integrated public systems can form the starting point for this effort. And integrated systems address access, cost, and quality because they provide multiple points of access. They get the patient to the right place at the right time for the right level of care, and they get information to providers at the point of care, and healthcare is a knowledge and information business. Now, this is Denver Health, and I want to show you that my comments about the integrated system being the bedrock of the solution is based on real data, not on a theoretical model. And unlike a model of the Mayo Clinic or Intermountain Health, this is a model in the public sector that is aimed to serve vulnerable people. So what are its components? Well, obviously, we have a hospital, which is now the busiest in the state of Colorado. Public health is not usually included in integrated models, but it is important if you are going to move from the concept of care for the individual to care for the population of a community. All the federally qualified health centers in Denver are part of Denver Health. This is extraordinarily unusual. If you go to San Francisco, for example, they have 10 federally qualified health centers. They're all independent. They don't share data. They don't share administrative structure. And that's multiplied throughout the country. We have our own HMO, which mainly is aimed at the public plans. We do Medicaid, Medicare, child health. Denver Cares is our 100-bed non-medical detox unit, and it emphasizes the importance of having ways to get people to the right place at the right time. We do not bring public inebriates to our ED and admit them to our hospital with a $50,000 workup each time they're intoxicated. We do correctional care. We staff the city and county jail. We have a locked facility on our campus, and I hate to say this, but in our society, this is an important point of entry for vulnerable people. School-based clinics are another important point of entry for vulnerable children. And all the school-based clinics in Denver are part of Denver Health. We have a call center, and an important component of that is a nurse line, which is 24/7, multi-language capabilities. We get 90,000 calls a year. We give out prescriptions on that line. And if you're vulnerable and you don't have a car and you're sick, this gets you out of calling the ambulance and going to the ED, and the patient satisfaction is 98%. The 911 system is also part of that and links sort of the most acute care to the rest of it. Our system is staffed by 265 employed physicians, which aligns the physicians with the rest of the enterprise. They're all full-time faculty at the School of Medicine, but they work for us. And the whole system is linked by a single image electronic medical record with a single patient identifier, a robust data warehouse, and registries across many different things. So what does this system do for access? Well, as you heard from the mayor, we take care of 1 in 4 people in Denver. 37% of Denver's babies are born here. 35% of Denver's children get their care here. And it provides access to the most vulnerable. 70% are ethnic minorities, 30% are non-English speakers, and 85% are below 185% of federal poverty. Now, so we provide access. Do we do it in a cost-efficient way? I'm sorry, the mayor left. I always like to show him this slide. This shows our unsponsored care, which went from $100 million in 1991 to a projected $360 million this year. The blue is the city's contribution. There is no other entity who for 18 years can have a constant tax subsidy from its mothership. So for the taxpayers, it's cost effective. What about for payers? This is our Medicaid charges per day at Denver Health and the other metropolitan peer hospitals. We're about 30% below. Now, so it does do access, it does do it at a cost-efficient manner, but what's the quality? Well, this is mortality data. My old grandfather, who came from Italy, used to say he never wanted to go into a hospital because you only go out in a box. Now, so he understood mortality is the end game. So this is our medical mortality from the University Health System Consortium data. The black is expected mortality. The yellow is Denver Health's actual mortality, has been below expected every quarter we've measured it. Last quarter we had the best hospital survival rate of any academic health center in the United States. And I would remind you, our patients haven't had lifelong luxury. This is heart attack care. There are 5 things you're supposed to do for every patient. We do all 5 every time. This is because we have computerized provider order entry with order sets. It's not every man on his own horse, which I know is the Colorado way. 92% of our kids are fully immunized. 61% of our patients have their blood pressure controlled compared to a national average of 34%. Again, because we have registries for all the patients and information passed back to the provider at the point of care. So I think what can be learned from this is that integrated models of care within the public sector can care for the most vulnerable populations in a cost-effective manner and provide extremely high quality. I think that if you're going to do this at a federal level, you might not be able to get all these pieces in one fell swoop, but the key pieces, I think, in the public sector are the disproportionate share safety net hospital, public health department, all the federally qualified health centers, the school-based clinics, and we must funnel the public patients' Medicaid chip through these integrated models of care. So what insights does this provide? I think, first of all, payment models should drive towards integration. I think we need to get back to capitation, but since no one likes that word, we could do global bundling. That the federal funding streams should drive to public system integration. We are putting lots of money into community health centers, into DISH, into school-based clinics, public health, and HIT, and this money should preferentially go to those entities that are willing to create integrated models of care. And my grandfather always said, money talks, and if we did this, we would have integrated public systems quickly, and then public insurance should drive patients to high-performing integrated public systems. Thank you. Thank you.